Well, hello everyone, and welcome back to Science in the Age of COVID-19. We hope that everyone is staying safe. Today we are delighted to host Dr. Neil Ferguson, a professor at Imperial College in London, UK. As almost everyone in this series, of course, Dr. Ferguson was working on something else before COVID-19 came on the scene. In this case, pandemics of mostly influenza and dengue, with forays into other pathogens. Dr. Ferguson will be speaking to us today largely about the so-called UK variant, B.1.1.7. As I'm sure all of you are aware, there are reports, but that I would say at this point, there's clear epidemiological evidence of greater transmissibility. He will tell us about that, and suggestions that it's more deadly. So, and of course, maybe he will touch on the other variants emerging around the world. We are all very curious about these issues. So, Neil.
Thank you. And it's a pleasure to be here. Yes, I'm going to mostly nearly entirely focus on our analyses of B.1.1.7, the UK variant. I'll touch right at the end on a couple of other variants, which may be of even greater concern. So what I'm going to, topics I'll cover today are just a little bit on the emergence of B.1.1.7. The data sources we've been using to analyze its transmissibility and severity, and then a little bit about where we are in the UK as a result of this variant, just a little bit of summing up. So I'm not sure if this animation will work, and this is completely lifted from Trevor Bedford's very nice website, nextstrain.org, but it nicely shows the evolution of SARS-CoV-2 in terms of the variety of new variants which have come up over time. And you'll see in a second the UK new variant come up. Bear in mind, this is a little bit biased by the fact the UK does nearly half the world's sequencing of SARS-CoV-2, but nevertheless, I mean, pops a bit there quite early, together with the South African variant you can see at the bottom in a slightly lighter shade. And one benefit we've seen in the UK is just the sheer amount of sequencing data available, and I'll come on to the other advantages in terms of data as well. Epidemiologically, what we saw is retrospectively, I mean, this strain first emerged probably in Kent, can't be absolutely sure, but probably in late August or early September, started spreading exponentially, but obviously from very low levels, and really became epidemiologically significant in November and then into December. And undoubtedly has been exported around the world as these viruses travel relatively easily. Is almost certainly present in every EU country, but EU, like the US, for instance, has heterogeneous sequencing capacity at the moment. Almost certainly it's probably present in nearly all US states. In terms of genetic characterization, and I'm not a geneticist, I should say, I mean, clearly there are a large number of changes. The ones we're most concerned with are in spike, particularly obviously the N501Y, which is of concern. The 6970 deletion is advantageous from a surveillance point of view, as I'll talk about in a moment. And then phenotypically P681H, so I'm told, potentially assists in binding. In terms of the origins of this virus, kind of epidemiologically, you can see, I'm just looking at the divergence of this strain in the plot on the right from pre-existing lineages. It accumulated a lot of mutations very suddenly. It wasn't incremental evolution. And so as Andrew Rambo has pointed out, that's probably suggestive of within-host evolution, perhaps in an immunocompromised, chronically infected individual. We'll never know to be sure, but we have seen this sort of pattern before. In terms of the data we've been analysing in the studies I'll show in a moment, first of all, we have genomic data. Since October 2020, the UK has generated, and this is slightly out of date now, but of the order of 55,000 SARS-CoV-2 genomes, including 14,000 ones of this variant. And secondly, we're very assisted by the fact that, not uniquely, but fairly unusually, the UK uses the Thermo Fisher TaqPath assay for its largest community testing PCR labs. That covers about a third of the testing which goes on in the UK, and that has both, as well as N and ORF1ab, also includes spike as a target, which is unusual for most PCR testing for SARS-CoV-2, and that allows us to use the fact that the 6970 deletion causes that target to fail. So it's not a perfect proxy for B.1.1.7, but it's, in recent months, certainly the last couple of months, has been a very good proxy for B.1.1.7 and allows us to have a much larger data set to look at the spread of the lineage and its epidemiological properties. And finally, we have some clinical data. At the moment, mostly we can link PCR testing in the community to a degree to mortality data. And I'll talk about that, the subset we can do that linkage for. We're awaiting there's a lag on hospital data, and in the next few weeks we should have the ability to link to hospital data as well. So I'll talk today about the impact, or the changes in this variant on transmissibility, and more tentatively on severity. I won't talk about immune escape. I mean, all the virological, immunological, at least in vitro studies conducted to date would suggest that this is not even a partial escape variant, and we have more concerns about P1 and the other variants, of course. So first of all, turning to just looking at how this variant has spread in terms of its frequency among all genomes sequenced in the UK. Here I'm stratifying by region of England and looking at the frequency of the VOC, means variant of concern, means B.1.1.7. And you'll see it almost certainly emerged first in the southeast of England, likely Kent, grew to really quite high frequencies even by mid-November, certainly by early December, it was a majority variant. And then closely followed by east of England and London. Other regions, I mean, it's been spreading geographically within the country a little behind, but it is now the majority variant across the entire country. If you plot the log odds of frequency, then quite simple theory tells you that the slope of the log odds curve gives you a measure of transmission advantage over other lineages in the population. And making that a little more quantitative, we estimate about a 50% increase from that simple linear regression in the reproduction number, adjusting for the six and a half day generation time of SARS-CoV-2. We can go one step further using the sequence data available. So if you use a time-rooted tree, then you can use phylogenetic estimation of the effective reproduction number using effective coalescent theory to estimate the effective population size of the variant over time. So this is not, it's a proxy for the number of people infected, but let's say it's proportional to the number of people infected over time. You have to be slightly careful in doing this to get proper spatiotemporal sampling. We're doing that with a small subset of 776 genomes, using two different coalescent models, one a non-parametric maximum likelihood model and one a Bayesian model, can give you direct estimates of the reproduction number of this variant over a period of about 6 weeks or so from November to December. And we estimated really a kind of 58% growth rate per week, which if you translate that into a reproduction number is about 1.59. And this is in the context where other variants basically had a reproduction number of about 1, basically flat incidence over time. Turning to the S-gene target failure data, SGTF data, which is much more numerous even than the sequencing data. If you just look at this raw data over time, then it tracks the frequency of the variant as revealed through genomic data very well, particularly if we correct it for the presence of other lineages. There are a few other lineages which were present back in September, October, which also caused S-gene target failure. And again, you can follow the same sort of analyses, though I won't present in terms of just simple regression, come up with very similar estimates of transmission advantage, but I'll go on to the more sophisticated analysis we did. There are some subtleties to using S-gene target failure, though, as a proxy for the variant. First of all, I should say we have this S-gene data for about 1/3 of UK community tests. So that's of the order of 130,000 tests a week. And that means we have sufficient data to actually estimate the incidence of this variant at fairly fine spatial temporal resolution. I've already mentioned we can correct for the existence of previous lineages. The precise definition you use to determine target failure of the S gene, and therefore what is, let's say, S plus versus S minus, is a slightly subtle one. It requires you, in reality, what you get out of PCR assays is CT values for each of the targets, and we have to define evidence-based thresholds for defining what we can call as the variant versus non-variant and compare that with genomic data. And we've been refining those with the help of Sanger and Public Health England over time. And our current view is probably the most reliable approach is to only attempt to classify samples where you have CT values, so that should say under 30, not over 30, under 30, sorry, no, that's accurate. So classify samples which have a CT value under 30, values where you have N and ORF over 30, then it would imply a relatively low viral load, and S-gene dropout in such contexts could just be down to not a lack of amplification rather than actually failure of the target. And so by requiring CT values less than 30 on N and ORF, you restrict yourself to samples with enough, basically, RNA there to be sure of the target. And you can see it makes a difference in these plots that if you don't do it, then you slightly underestimate the frequency of the variant. You also get some oddities in recent times. If you just use previous definition we've been using, you apparently see a drop in frequency, which isn't revealed in the genomic data or this more refined definition. If you just look at, though, take the S-gene target failure data from PCR testing and just plot the numbers of cases per week of S-gene negative and S-gene positive, and then the total number of cases, bearing in mind that only 1/3 of them have an S-gene readout, you see some kind of clearly striking trends. If you go to Kent and Medway, where this isolate was first detected, then you see during the period of the second English lockdown, November to December of last year, indicated by the 2 red lines, that flat or even declining incidence of non-variant, but quite rapidly increasing incidence of the variant itself. And you see that in a number of other areas where already had high frequencies of the variant. It was accelerating during that lockdown. I should say during that lockdown, schools were open, unlike the first UK lockdown. In other areas, the lowest row of graphs here, you see a decline in cases overall during the lockdown. And those are areas which tend to have very low frequencies of the variant. So you can use this S-gene data in a number of ways. So, I mean, a very simple empirical analysis is to look at just weekly growth factors, cases of either S plus, the old virus, versus S minus, proxy for the variant, in week +1 divided by cases this week. So how much is our case numbers increasing for each of them week on week? And then you calculate that independently for S plus and S minus and look at either the ratio of those growth factors or the difference. And that's what's been plotted here across it's a 5-week period, 4 weeks of growth factors and 42 regions of England. And what you see is the multiplicative advantage on just these weekly growth factors is of the order of kind of 1.8, 1.9, fairly independent of the frequency of the variant in that week. The additive advantage of the order of 0.75, 0.8. If you correct those estimates for the generation time to turn them into an estimate of how much the reproduction number is increased, you get a multiplicative advantage of about 1.74 median and an additive advantage of 0.63. And you can just see from the scatter plot, the fact that curve on the plot on the left, the great majority of points are above the line of 1, and on the right above the line of 0, that there's a significant transmission advantage. People have raised the possibility, though, maybe it's growing faster, not because it has a greater reproduction number, but really what's called the generation time is shorter. So maybe people become infectious earlier and infectious for less time, but it's actually no fitter in terms of transmission. Well, if that was the case, it would give faster growth in areas where the reproduction number was above 1, but it would also, the variant in that case would decline faster in areas where the reproduction number was less than 1. What we actually see is something very different, though. We see a very striking preponderance of areas. Well, I'm pairing weeks with areas here. So area week pairs where we see growth of the variant, but decline of the non-variant viruses, and only one area week pair where we see the opposite. And so that's really quite strong statistical evidence that this variant transmits faster, it transmits at a higher fundamental reproduction number. Then we undertake a number of analyses where we either estimate the reproduction number of the entire epidemic over time by region and look at the correlation between the reproduction number and the frequency of the variant, or using the S-gene target failure data, we directly estimate separately the reproduction number for the variant and non-variant strains. Taking the first of those, what this plot shows is the relationship between estimated reproduction number by region and by week with the genomic frequency. This is not S-gene data, but the genomic frequency measured in sequence data at that same time point. And you see a kind of clear, noisy, clear correlation between high frequencies of the variant and higher reproduction numbers. You can make that more statistically rigorous just by regressing reproduction number estimates by area and by week against the frequency of the variant. And whilst we're using nonlinear models now, if you're just using standard linear regression to do this, you can only really, in a principled way, do an additive model. So we're saying how much would the reproduction number be increased by in terms of an additive effect if you went from 0 to 100% frequency of the variant. And for a variety of different models, whether we have a fixed effect model, random effects, frequentist or Bayesian model, and whether we're using S-gene target failure data or genomic data, or whether we do it at 2 different spatial resolutions, we get very consistent estimates of the increase in the reproduction number, basically in the 0.4 to 0.7 range. Random effects models give a slightly higher effect size just because of the more constraints on regional variation. We're controlling, I should say here, for temporal and spatial variation in the intrinsic reproduction number. If we directly, using the S-gene target failure data, estimate the reproduction number for the variant versus the non-variant, then we can then look at the extent to which those estimates differ both in space and over time. We see really across nearly all regions which had appreciable fractions of the variant and multiple weeks, a significant advantage to the variant. And that's shown in the scatter plot, which shows estimates for the same week and location for the variant on the y-axis and the non-variant on the x-axis. And the fact that most of those points lie above that x equals y line is suggestive of a significant transmission advantage. And again, we get here an estimate, again, it's around the 60% mark, mean ratio, if we compare the ratio of reproduction numbers, about 1.56. I should say those credible interval, we're updating this to do a joint analysis, those credible intervals are probably a little too wide. We can also look at effects by age, given the amount of data we have. And what we saw, first of all, I mean, what you're seeing plotted here is the proportion of cases of either variant or non-variant in 4 different age bands, 0 to 10 at the bottom, 11 to 18, and then right at the top, the biggest age band, 19 to 49, and the one in the middle is those over 50. And so you do see a lot of variation over time in UK data in the age distribution of COVID cases. And this really reflects the effect of social distancing measures on contact rates in different strata of the population. Importantly, from about weeks about 46 to 50, we were in the second lockdown in this country, where adult contact rates reduced a lot, but children were still going to school. And you see, therefore, a drop in the proportion of cases in adults and an increase in children. That's a slightly larger increase for the variant than the non-variant, particularly in London, but it's present in other areas. We don't think this is because the variant particularly targets children in any way. The transmission advantage doesn't appear to be larger in children. It's more with a higher level of transmission, a higher reproduction number overall. School outbreaks became more explosive, particularly in late November and December in the UK. And this may be a problem for containing these variants going forward, that whilst previously there was limited evidence for really self-sustaining outbreaks in most secondary schools, obviously lots of evidence for universities, this may no longer be the case with this new variant. Just turning to the severity analysis we and other groups have been undertaking, and I should say it's really Public Health England and the London School of Hygiene and Tropical Medicine which led this work, and we just undertook a number of complementary analysis to their survival analysis, which I'll present in a moment. I mean, all of them rely on data linkage, linking PCR testing data in the UK to the single global COVID-19 deaths line list, which Public Health England maintains, which is basically a list of everybody who's been tested and within 28 days of dying of COVID. There are a lot of challenges in doing this sort of analysis. It's much more complex than assessing transmissibility. First of all, at the current time, only about 50% of the people admitted to COVID who are then tested in hospital, admitted to hospital and then tested for COVID, have had a community test, we call a pillar 2 test, before admission. So the other half, we can't link to community test results at all. And the people who do typically have a community test before admission tend to be younger than the people who mostly die from COVID. And so we can only link about 25% of those who actually die from COVID in hospitals to a community test result. And only about a third of those community tests, so about 10% of deaths overall, have a S-gene result. So we can link, therefore, the variant and non-variant, that classification based on S-gene target failure, to mortality only in about 10% of deaths. And unfortunately, in some ways, hospital PCR testing uses different assays with different targets and doesn't test for the S gene. Beyond that, delays to death can be substantial. And then, from infection to death can be certainly as much as 3 or 4 weeks. And then deaths can take a week or more to actually enter the database we analyze. The final point is if you're comparing the variant to non-variant using a proxy which has namely S gene target failure, which has imperfect sensitivity and specificity, that's most reliable when SGTF and non-SGTF have case numbers are at roughly equal levels, roughly equal frequency in the data. If you're at the point we are now, where in London, well over 90% of people who have PCR tested test negative for the S gene, then it's unclear whether the remaining 10% are also actually just affected and it's just sensitivity of the assay or specificity of the assay. And likewise, if you're at the other extreme, with very low frequency of the variant, it's not clear whether it's the variant there, if we go back to early November, for instance, in the UK, or another lineage which might be causing that same signal. And the last caveat, which is perhaps the most important one at the moment, is we're not currently able to link the community testing data to hospital admission data. There are longer lags on getting through hospital admission or what's called hospital episode statistics through than there are getting mortality data. And that will be critical for verifying what I'll talk about in a moment in terms of conclusions. So as I already said, there have been multiple studies which have been informing our understanding of the severity approach. And we specifically, London School did a very nice survival analysis. So we focused on non-parametric stratified endpoint analysis, by which I mean we stratify the data, the case data we analyze by time, by week of when they were first tested, by geographic area. We use various stratifications, but typically we use this what's called NHS STP area, about 42 of them in the country, by ethnic group, because that infection levels vary a lot and mortality levels vary a lot by ethnicity, and 9 different age bands, which particularly give give discrimination in the older age categories where most deaths arise. And then we apply 3 different methods for, in some sense, a stratum to stratum comparison of mortality rates. This matched comparison of S gene deletion and S gene positive case fatality ratios in what turns out to be about 13,000 strata in total. And that stratification is essential. If you just do a naive comparison, you really don't see a signal at all. And that's indicated in the graph here, just for all the data in England. The top one shows pillar 2, these cases where we have an S gene result by week, stratified into whether they're S positive or S negative. And you can see the variant accelerating towards the end of the year, weeks really 49, 50 onwards. And then you see the data from the deaths, which we've been able to match to those cases over time. If you just plot the case fatality ratio for S plus and S minus from the raw data, you actually would probably draw a conclusion that the variant was less lethal than the non-variant. But on the right-hand side, I do this case control weighting, where you match case numbers in each of these strata before you calculate average case fatality ratios. And you see a rather different pattern emerging, where whilst the data is noisy and the signal becomes clearer right towards the end of the year when the frequencies are higher and the numbers of deaths are higher, but generally the points are above 1. You can also look at that in just the region of most interest, where the frequency of the variant took off earlier, and see a very similar pattern. Again, you don't see much of a signal, slightly more now, but not much of a signal just from the raw data. But when you properly stratify the data and then match like for like, you see the signal emerge. So our basic statistical hypothesis here is that the case fatality ratio in community tested cases is higher in S gene target failure cases than in non-S gene target failure cases. And assuming a kind of constant multiplicative scaling of the CFR across all strata. And it's very important to note that, as we know, case fatality ratios vary a lot between different ages and different other strata of society. And so they can vary 100-fold between the youngest in society and the eldest. So we use three closely related methods. One is a case control weighting approach applied per stratum. This is in essence a case control study, but makes full use of the data rather than just randomly selecting matched controls. One is a standardized CFR analysis, which is commonly used in the demographic literature to look at standardized mortality ratios. From a fundamental statistical basis, it's less robust, but you'll see, and it gives less power. But and the final is conditional logistic regression, which is probably the gold standard for analyzing matched outcome data like this. And I'm reporting the mean ratio of CFR for the S minus, the variant, to S plus across strata here. So this is a kind of busy table, and I won't go through all of it. What I'm presenting here is for two different definitions of S gene target failure. The default one we're using now is the block at the top, and then the one previously used is the block at the bottom. But they give rather similar estimates. And then the top row on each is when you analyze all strata, and then I show various stratifications where you select only certain groups below. And so overall, and this I should say is over a period of epidemiological week 46 through 52. The reason we cut off at week 52 is to allow sufficient time for deaths to be recorded after that cutoff date. And so we see, depending slightly on the method, the case control weighting and conditional logistic regression basically give almost identical results. Standardized CFR approach gives very slightly lower estimates with less power. But they're broadly statistically consistent, that we're seeing of the order of a 40 to 50% increase in the case fatality ratio based on community testing data. And there are hints of variation with age and region and time. In particular, if we stratify to week less than 50 and week 50 plus, we see quite a big difference. Again, we don't have the power to resolve statistical significance in that, but it makes sense because there were many going back up to this curve. You'll see before week 50, we had many fewer deaths from, particularly deaths, but also cases from the S gene negative. Also in that time period, it's more likely that the S gene target failure will be down to a different lineage, and the signal becomes stronger after week 50. We also see a somewhat stronger signal in 70-year-olds and plus, but bear in mind that 2/3 or more, I think 70% of deaths occur in the 70 plus category, and so we have really quite limited power to resolve an effect in younger age groups. There are significant caveats to this. I mean, the mortality analysis is likely to be strengthened with another 1 or 2 weeks of data. Beyond that, it won't get any stronger because the frequency of the variant is now so high that we can't really trust the PCR tests, which are apparently testing positive for S gene. I mean, we know already that occasionally we get S gene positives from the variant out of the data. So, and we just won't have enough controls. We won't have enough people being infected with older variants to continue the comparison. We also don't have, because we don't have hospital episode statistics, we don't have data on people who are recovered. We just know a certain number of people died and then others we have no information on. And so knowing definitively that people have recovered will improve the power of the analysis and its robustness. What we do know is from other groups' analyses is preliminary data suggests we don't have an increase in the case fatality ratio in hospitalized patients. So once people get admitted to hospital, they don't seem to be any more likely to die than if they're infected with the B.1.1.7 compared with other lineages. And that would suggest just an overall increase in, I mean, there's probably what I would expect it to manifest as, but if there's some increase in severity, it's manifest as a certain, higher chance that somebody will develop more severe symptoms and therefore be hospitalized. And so if this severity signal is actually valid, it should be reflected in an increased chance of hospitalization for variant cases. That's why we're eagerly awaiting being able to do data linkage to hospitalization records, and that will be critical. And so until we do that, these conclusions are going to remain quite tentative. What's the current situation in the UK in the presence of this variant? Well, it's, as I already said, it's the dominant variant across the country now in terms of the majority of cases are variant. Varies still a little by region. South is ahead. It has caused major challenges in control, as you probably know from if you followed international news at all. The UK is suffering the worst second, so third wave of this pandemic across Europe. We're above 1,000 deaths a day and have been for a few weeks now, which, bearing in mind, it would be equivalent to roughly 6,000 deaths a day in the United States, allowing for population size. And we have 38,000 people in hospital, which represents over a third of our hospital bed capacity in the country. However, the new lockdown, now schools have shut, is bringing case numbers down, as you can see in these graphs just captured from the UK dashboard today, just across the country, but it also appears to be, albeit at different rates across each region as well. But whilst PCR tested cases are going down quite quickly, there are clearly lags in the system so that hospital patients are only declining much more with a lag and much more slowly, and deaths are not yet declining. And so we have a very difficult few months ahead of us. I mean, we are rolling out vaccination very quickly compared with most other countries, but we have yet to see its impact on mortality numbers. In terms of what I'm worried about at the moment, beyond everything I've described so far, I think much has been talked about both the South African variant and the new Brazilian variant. But I mean, the situation in Manaus really is very concerning at the moment. Nuno Faria, who's Brazilian, works in Centre I Direct, has been doing a lot of these analyses of the Brazilian epidemic overall. And he did a nice analysis with many colleagues from Brazil, which tried to estimate, based on serological data, the attack, and this was published in Nature a couple of months ago, estimated that some 70 to 75% of the population of Manaus were probably infected in the first wave of the pandemic. And the fact that they have this catastrophic second wave with this new variant, and it is being driven by this P1 variant, is particularly concerning. And whilst we don't have definitive evidence about immune escape, it does throw into question the whole notion of herd immunity if we can have such a catastrophic epidemic, even just less than a year after a first one. And so looking at exactly what this new lineage means for immunity, both naturally induced immunity and vaccine protection, will be critically important. So my last slide. Clearly, this is not where we wanted the world to be. Certainly not where we wanted the UK to be at this point. I mean, the new variant B.1.1.7 has posed really enormous challenges for my country, cost many more lives than would have otherwise been lost. I mean, the second lockdown was achieving control of the previous lineages in the UK, despite schools being open. And the massive acceleration in case numbers just in the last 8 weeks now, despite a lot of controls being in place, is testament to its increased transmissibility. Most of those additional deaths, unfortunately, and hospitalizations have been due to the increased transmissibility, though increased severity may have also contributed. I mean, I believe, and then they've been validated by other groups' analysis as well, that our estimates of increased transmissibility are robust. I didn't have time to go into it, and we do expect that transmission advantage to vary somewhat by setting. In the household setting, with lots of close contacts, where transmission, even of older variants, was very intense, probably the transmission advantage manifests more like a 40% increase in secondary household attack rates. And we have data to support that from contact tracing studies. Probably in a more infrequent, in the context of more frequent but briefer contacts, for instance, in mass gatherings or indoor settings with lots of people, we're probably more likely to see something like an 80% increase in transmission. And so, depending on the social distancing measures you have in place, and then the actual, what you see in terms of transmission advantage may well vary over time and by context. But overall, these estimates are robust. The estimates of increased severity are very much preliminary until we can get a secondary data source. And really the secondary data source we're waiting for is being able to link to hospital admission data. And then finally, just to conclude, I mean, the obvious statement, but it remains even more the case now than previously. I mean, vaccination remains really the only long-term exit strategy here. And what the presence of this new variant will mean for the UK, and I think for everybody in Europe and most likely in the US, is that we will not be able to relax social distancing as fast as we previously hoped to, even in the presence of vaccination, high levels of vaccination. We don't have one bit of good news, and silver lining is certainly for B.1.1.7, we don't have any evidence of immune escape. But even partial escape for the P1 and B.1.351 variant, the South African variant, and lowered efficacy would pose even more challenges. Thank you.
Thank you, Neil. Fantastic talk, a very timely one. So thank you. And we obviously have a lot of questions. Speaking of questions, audience, please feel free to go ahead and type up your questions in the chat box. We will call you to ask your questions, or if you would like, we can read out your questions as well. So as the audience questions start to come in, let me ask you this. So we've clearly seen the importance of genomic surveillance. Genomic surveillance is critical to combat the new viruses that are evolving. And even before genomic surveillance, detection is critical. At this point, the S gene dropout appears to be a good proxy for a first-pass detection of these variants. And the S gene dropout is because of the del 6970 mutations. However, we are starting to see different flavors of these variants. We have the UK variants, we have the South African variant, and the troublesome P1 lineage. And the del 6970 appears to be co-occurring in all these variants. So in other words, what I'm trying to come to is that S gene dropout cannot possibly distinguish between the different variants. So is deep sequencing the only way that we can differentiate between the different mutants? Because not all countries are equipped with the high-level, high-throughput genome sequencing that UK is.
So I'm not sure about deep sequencing, but I think sequencing certainly will be essential. And we're very conscious, even in the UK, that from now on, 6970 and the S gene target failure is not going to be very much use anymore. Basically, all our virus increasingly will be negative on S gene. And if we do want to distinguish between, for instance, variants which do and don't have E484K, which is of particular concern, obviously, we are going to have to rely on genomics. And so even in the UK context, we're thinking hard through the what's called COG UK consortium of doing what hasn't really happened up till now, which is using this massive sequencing capacity we've developed in a much more real-time manner to inform epidemiological surveillance. And so there's we're trying, at the moment it takes us about 2 weeks from when somebody's tested to when we get a sequence, and we'd like to shrink that time and also scale up sequencing even more and targeting in particular settings, so that we have a clearer indication if we start to see B.1.351 or P1 taking off within the UK, we have plenty of notice of that. I should say it's unlikely either of those variants, they probably share the same sort of transmission advantage B.1.1.7 does. But in my view, and we don't have any, I mean, the preliminary, it's much harder to do the analysis of those variants. Both the epidemiological and the genomic data is poorer. They appear to have a transmission advantage of the same ballpark as B.1.1.7. So in some sense, that is good news for the UK, because our variant will in some sense resist invasion, except for immunity. It's unlikely P1 or B.1.351 is more transmissible than B.1.1.7. In other countries which have much lower frequencies of any of these variants, invasion could happen quite quickly.
Yeah, sounds good. Thank you. We now have an audience question. Bill, would you please unmute yourself and ask your question?
Sure. Can you hear me okay?
Yes.
Yes. So my question was about, could you discuss the relationship between the transmission rates and the severity analysis with respect to possibilities like viral load? And I was thinking more about the paper and the work about variolation out of UCSF.
Yeah. So, I mean, interesting speculation, and it makes complete sense to me that increased, certainly upper respiratory tract viral load would increase transmissibility and might well be a risk factor for increased severity, and may allow seeding to lower respiratory tract, say, more easily, or happen slightly more frequently. But it is speculation at the moment. I mean, the sort of research needed to really look at the mechanisms of either increased transmissibility or increased severity is going to take months, if not years, as compared with these sort of associative correlative analysis I've shown today.
Thank you.
Thank you, Bill. Thank you, Neil.
Hey, Neil, I've got a couple questions that piggyback on Sarada's question about S-gene dropout. Was it just random chance that your PCR primers overlapped 69, 70?
I think you'll have to ask Thermo Fisher. Bizarrely, it's still commercially sensitive information.
Okay.
Exactly what regions they're targeting, but clearly they do.
Okay. And then I had another question. So it looks like your definition of target failure required really strong signals for both N and ORF1AB, just to make sure that it wasn't loss of sample in entirety. My question is, does that potentially convolve in other sources of noise? Because, I mean, not B.1.1.7, but other strains, for instance, have an ORF1B deletion.
Yeah, so we have tested that, and we're actually seeing, and we're trying to work out why, we're seeing increasing frequency of single positive variants with low CTs in community testing. Increasing numbers of N deletions, actually. And despite the CT of ORF1AB being well below 30, we're trying to work out the significance of that at the moment. Well, should I say my colleagues in the Sanger are trying to work out the significance of that and link it to genomic data. We have played with a number of different definitions of S-gene target failure in terms of these sort of analyses. You can require just one of N or ORF1AB to have a low CT value, and the conclusions don't change significantly.
Mm-hmm. Yeah, I mean, for all the reasons that you said, I mean, I think we can all agree that genome sequencing is the way forward, but that's just much easier said than done, and this is all flying by the seat of our pants. So it's good on you guys for figuring out a proxy. Sarada, you want to go next?
Yes.
And audience, keep the questions coming.
Here's an interesting question. We see all these viruses evolving, these variants evolving, because they are obviously able to perform better in the fitness landscape. I'm just curious because we are starting to see all these variants coming up and also being able to perform better as the therapeutic options are also ramping up. Do you see any correlation? Could that be the selection pressure?
I mean, I doubt that therapeutic options are going to really impose a significant selection pressure on this virus, given probably only 2% of people are hospitalized. I think what it potentially does do, so there's a small subset of patients I think we need to be concerned with in terms of being potential sources of variants and the potential selection pressures which may apply to them. That is potentially chronically infected, immunocompromised patients, where you may well be most likely to use monoclonals, whether you use vaccines is another matter, and impose, in some sense, an immune selection pressure on the virus, and have the potential of generating variants which are, like this variant, multiple changes away from pre-existing lineages. And so it's not so much that at a population level, I think treatment is a very minor selection pressure, but generating just by chance these adapted viruses which happen to be immune escapes is more of a risk. Obviously, looking longer term, as we roll out vaccine, as for influenza, as with any pathogen, the vaccination will impose potentially a very significant selection pressure, particularly if it reduces transmission. We will just have to see the capability of the virus to escape that. I mean, we haven't historically, human coronaviruses historically haven't been quite the same as flu in their ability to escape immunity, but then I'm not sure whether we've really demonstrated long-lasting neutralizing immunity against endemic human coronaviruses anyhow. What we know is that people get infected every couple of years with endemic human coronaviruses.
Neil, I've got another one. Would you mind pulling up your slides again to slide 11?
Sure.
I've got a question in regional variability in the strain.
This is just a rather arbitrary subset of areas.
I'm sure. I'm just wondering why, like areas like Cheshire and Umber jump out at me as, having about the same caseload, but seeing a dramatic drop in the.
So what we always see is between those red lines is when the lockdown was in place, and we see and have seen throughout this epidemic, let's say, varying effectiveness of social distancing measures in different populations. Also, the pre-existing immunity was rather different. So Merseyside in particular saw, prior to the time period being plotted there, saw a very large second wave. It was the area of the country which was of most concern in October. And probably over 25% of the population got infected in that period. And so it probably starts from a higher immune baseline. But areas like Hereford and Worcestershire is a very rural area, and typically we have seen lower transmission rates in rural areas and more effectiveness of social distancing. So like everything else, and like all of these kind of case control type studies, the reason for stratifying by area is to try to control for that spatial variation.
Yeah, interesting. Okay, so Sarada, you go.
Yes, I'm just going to now piggyback a question on this. Do you see any correlation between transmission and, for example, travel? So could we use these genomic surveillance data to tighten some of our travel policies?
Interesting question. Well, of course, there's a lot of focus on travellers at the moment, and UK sequencing, some of the UK sequencing effort is being directed at travellers, which is why we're picking up imported cases from South Africa, Brazil, and elsewhere. I'm not sure. I think it's good for surveillance. Whether it's good for control is another matter. I would need to think about it more. It's not obvious to me. It's going to make an enormous difference.
Right. Thank you. And we now have an audience question. Brian, will you please unmute yourself and ask your question?
Thanks so much. A great talk. I just wonder if you had any ideas if and how the social distancing guidelines should be updated, given that it spreads more easily. Is there any? Do you think that, for example, we have a 6 feet rule here in the US? Do you think it makes sense to strengthen those guidelines?
It's an interesting question. I think it very much depends on context. Well, first of all, I should say a lot of the guidelines being adopted across the world are not really evidence-based. They're based on effectively, certainly not epidemiological evidence-based. They're based on intuition about transmission. I think it is more transmissible, but I think, for instance, outdoor interactions, socially distanced ones, I know of no data suggesting they pose any significant risk if long as you maintain that sort of 2-meter distance. I think where we need to be concerned is about indoor interactions. And I think what this new variant does is not so much change the measures we want to adopt, but it does really demand greater adherence to those measures and greater rigor in how they're implemented. I think it's encouraging. It wasn't obvious that it would be the case, but it is encouraging in some sense. The very rigorous lockdown England is now in is actually managing to control the spread of this variant. Case numbers are coming down fastest in London, but frankly, London is now at the same stage New York was back in. We estimate probably 35% of the population's been infected there at this point. So, and that probably is helping case numbers come down, but we're seeing case numbers now slowly coming down across the country, despite the presence of the new variant. I think what it makes very difficult is an exit strategy from those measures, though, because we sort of know we've estimated what effect it have of even reopening schools, and it's quite likely that that would be sufficient to then get case numbers going up quite sharply again, even keeping the lockdown in place in adults. And so it just adds to the need to get vaccine into people's arms as fast as possible.
Right. Thank you, Brian. Thanks, Neil. I have one question, slightly switching gears. So generally with SARS-CoV-2, we see a sex-related difference both in the infection and the manifestation of the disease, right? We see that men are affected more than women, and they also are really sick compared to women. Have you, in all your analyses, have you by any chance seen any same-sex difference in behavior with these variants?
So I didn't actually present, we have extended these analyses to, we can't really look at it in terms of transmissibility, and really all the evidence we have at the moment is that the sex differences in the kind of epidemiology of SARS-CoV-2 are related to severity more than transmission. What we see is the B.1.1.7 shows the same pattern in terms of the differential case fatality ratio and hospitalization rate between men and women as the previous variant. But it is, well, given the limitations I've highlighted, does appear to potentially be more severe in both sexes.
Oh, interesting. Thank you. Loren, do you have one?
Yeah, Neil, quick question. I'm guessing you guys don't have enough data yet. So reinfection. So, we know it's a, very rare thing, 1 in a million thing, to date, not something we should, stay up at night worrying about. Are you guys starting to see, did you have enough data to see, to say if there's a signal here for higher reinfection?
PHE, Public Health England, our CDC have been looking at a number of studies looking at reinfection. We can look at it within our community testing data for people who test positive multiple times, and we do see reinfection. I don't know the full numbers, but we've a few thousand reinfections now in that data set. And then there are more careful cohort studies, for instance, of healthcare workers, which have measured reinfection rates. And there was a nice, and I can't remember the first author, but a nice medRxiv paper out of the Siren study, which is a large healthcare worker cohort run by Public Health England, which looks at basically natural immunity and reinfection rates. It estimates the effectiveness of natural immunity and seems to suggest really a very high level of protection for at least 3-4 months, but then decaying levels of protection, increasing levels of reinfection thereafter, but still significant protection against reinfection. And bear in mind, this study wasn't just looking at symptomatic cases, it was doing asymptomatic swabbing. As for the variant, they have looked at the Siren data for the variant, and they can't find a signal at the moment of any higher levels of reinfection, any evidence, for instance, of even partial immune escape, but the numbers are really quite small.
Okay, well, there's some solace there at least. So, Neil, thank you. That was amazing. That was a lot of data to cover, very timely. Thank you so much for your time.
Thank you,
It's a
Neil.
pleasure. Thank you.
Stay safe and Godspeed.
Thank you. Bye.